our differentials were autoimmune encephalitis and versus PML iris, although the timelines didn't really fit. So this patient received high-dose corticosteroids and was plexed, but with no improvement in symptoms. Now this is where it gets really interesting. If you can see from the first to the second MRI, the transformation becomes unmistakable. You can see new hyperintensities on bilateral motor strips now, and this is reflected very clearly on the diffusion-weighted imaging, and you can see that they're predominantly gyral in distribution. The third MRI, which we did about a month into his second admission, now here it's unmistakable. You can see this florid bilateral flare hyperintensities involving mostly the posterior cortex bilaterally, and now there's also this thalamic involvement that wasn't in the previous scan. So what I'm trying to show is that there was very rapid involvement of the cortex. So we had an MDT involvement in management of this patient. Of course, the infectious diseases team was invited, and all the infectious causes were ruled out. PML was not likely, as the JC virus was negative, as well as the MRI findings, which were not compatible. He was not typical for HIV encephalitis, and SSPE was also ruled out as the measles was negative. We are very fortunate in Aga Khan as we have these weekly MDT meetings, and this case was discussed in the neurology and radiology MDT, and the pathognomic features of CJD were established. So just to go back, this is called cortical ribboning, and it's one of the features that is very characteristic of CJD. So this patient unfortunately died in ICU about 6 weeks after initial presentation, and unfortunately the family declined post-mortem. So on the screen, as you can see, are just some CJD mimics. It's a very difficult diagnosis to make, but the mimics are potentially treatable. So as I said, CJD is rapidly progressive and is universally fatal. So if there are any other mimics that you can treat, that's something that you need to diagnose for the benefit of the patient. So did our patient fulfill the criteria? This is the WHO diagnostic criteria, and you can see he met 7 or 8 of the diagnostic criteria. The only one that he didn't meet was the CSF for the RT-QuIC or the 1433 protein, which unfortunately we did not have the capability to send out. This is a paper that was actually also published from Aga Khan Hospital, and they also looked at a very rare variant of sporadic CJD, where the presentation is usually posterior, presenting with visual symptoms. And in this paper as well, they highlighted the diagnostic challenges, including the lack of access to those tests that I mentioned. So CJD in Africa, the data is very sparse. On the left panel, you can see the incidence of CJD is on the rise. The blue is the total number of CJD cases, and the orange is the number of sporadic CJD cases. And you can see most of the cases are sporadic in nature. On the right is a panel of worldwide cases of sporadic CJD reported, and there is no representation from African countries. And this is not because we are not, it doesn't exist, but it's rather that we don't have an established prion disease surveillance program. So what makes our case different, and I've alluded to this before, is just the kind of presentation that we had. This is all the literature that exists in relation to CJD and HIV, and in all of these cases, except for the one that they did in Sweden, it happened in very advanced and well-controlled HIV.